Hello and welcome to the COVID-19 update on Channels Television. I'm Millicent Walker. First, the highlights. Nigeria consistently records less new COVID-19 cases for 3 weeks and no deaths in over a week. It's the second anniversary of COVID-19 in Nigeria. We'll look at the journey so far. And new ease recommendations in the US will see 70% of Americans no longer needing to wear masks or keep physical distance. Thank you for joining us. A new study has found that Wuhan market was indeed where the COVID-19 pandemic most likely started. The study uses spatial and genomic data to establish a link between two lineages of the emergent virus and the Hunan seafood wholesale markets in Wuhan, China. The researchers also report that live mammals were sold at the market toward the end of 2019, showing a strong connection between the vendors selling the animals and the virus. Meanwhile, Nigeria logged 24 cases in 6 states. Here's more on the update.
24 additional persons in Nigeria have tested positive to COVID-19 in the last 24 hours. According to the Nigeria Center for Disease Control, the latest figures were reported from 6 states and the FCT, indicating a drop from figures reported earlier. Abia accounted for the highest number of cases with 7 infections. Lagos had 6, Edo 4, the FCT 3, and Kaduna had 2, while Osun and Rivers had logged 1 case each. The total confirmed cases in Nigeria now stands at 254,525. 20 patients have been discharged in the last 24 hours, increasing the total number of recoveries to 249,013. There was no additional death recorded in the last 24 hours, leaving the fatality toll at 3,142. Over 17.8 million eligible Nigerians targeted for COVID-19 vaccination have received their first dose, while more than 8.1 million of the population have been fully vaccinated. The total global confirmed cases have surpassed 435 million, while deaths are now beyond 5.9 million.
And it's the second anniversary of the first Nigerian case of COVID-19, and the country has recorded 4 waves of the pandemic since then, each one logging more infections than the previous. While the vaccines are life-saving for many, Africa still has the slowest vaccination rate. Let's take a look. Is it the beginning of the end? Nigeria's index case of the coronavirus was confirmed by the virology lab of the Lagos University Teaching Hospital, an affiliate of the laboratory network of the Nigeria Center for Disease Control. No one knew what to expect from a pandemic originally linked with China's Hubei province, but has spread its venom across the world in a short period.
We have never been before seen a pandemic sparked by a coronavirus. This is the first pandemic caused by a coronavirus.
Nigeria's first case was triggered through an Italian citizen who worked in the country and had returned from Milan.
When he came into my office, he had a really high fever. That was the first clue. And then the fact that he had stayed in my office for about 8-10 minutes, and instead of subsiding, the fever was still climbing higher. So I figured, okay, most likely COVID-19.
Contact tracing and monitoring in respect of the coronavirus index case presently receiving treatment in Lagos has been diligently and conscientiously pursued since the 27th of February.
The case numbers 2 years on is in its thousands, claiming lives along the way. Through the mutations and waves of the virus, the measures have moved from lockdowns in 2020 to bans on gatherings and reminders on the safety protocols, regular hand washing, maintaining at least 2 meters from the next person, and then the use of the face masks. Holiday periods across the continent proved to be one that saw an increase in infections, as more people decide to move around.
Because of the speed of traveling, you can be in Lagos tonight and be in Europe tomorrow, and even as far as China the next hour, something of that nature. So within a space of 24 to 36 hours, people have moved in different directions. So if any of them is carrying any disease, that's the easiest way. And this is one disease that is spread through the air.
How much did the arrival of vaccines in March 2021 have on the case numbers?
Over 80% of people who have died from COVID-19 since we started vaccination are those who have been unvaccinated. So there's a clear situation where if you're vaccinated, you're not likely to die. You're not likely to be hospitalized. If you're not vaccinated, then you are likely to die. You are likely to be hospitalized from COVID-19.
So far, the highest cases have been recorded in Lagos and the Federal Capital Territory, and the least or barely anything at all in Kogi State. After 2 years of COVID-19 in Nigeria, what are the lessons?
It's important that we monitor the trend of this through active surveillance and even passive surveillance. We have what we call integrated disease surveillance and response system that enables us to identify these infectious diseases, to monitor their threat, and to also advise public health action that will prevent the next pandemic.
For us now, we know what are the things we needed. We need good surveillance. We need good reporting. We need good laboratories. Those must be in place. And remember, when this whole thing started, Nigeria had, according to NCDC, about 2 or 3 laboratories. Now we boast about 140. But what worries me is that if you go to NCDC report, you find every week they are saying 50 to 60 of those labs are no longer reporting. So what's happening? And that's why I get a bit worried that we are not prepared even for the next one that is coming.
Whatever form future pandemic preparedness takes, it does appear that the world is now moving on, with many countries easing restrictions. Will we be better prepared if another pandemic hits? Remains to be seen. And 2 years after the first cases of COVID-19 were recorded in Nigeria, how have those years tested our resilience? The Nigeria Center for Disease Control Director General, Dr. Ifedayo Adetifa, joins us now, looking back and looking forward. DG, thank you for joining us on the program.
Thank you very much, Melissa. And may I just use the opportunity to thank you and the production crew of the COVID-19 update channels for 2 years of a really fantastic job providing useful updates to the public regarding this pandemic. Thank you very much for your support.
Thank you, sir. Now, in your experience of infectious diseases, where will you put COVID-19 in terms of virulence, science, disease characteristics? And this is compared to other diseases you've probably come across.
Well, COVID was new. That's the big deal. And in some of the earlier reports, especially the one by the WHO Director General, he did say, never before in human history had we had a pandemic caused by a coronavirus. So we didn't know anything about this particular virus, and we had to struggle to respond to it, look after cases, or in fact, identify cases, look after cases, develop diagnostic tests, develop management strategies at the same time as responding to it. So that was very difficult in terms of COVID as an infectious disease. For those of us in infectious disease practice, you have some sense of comfort because most of the diseases have been around and there's existing knowledge. You've been taught about it, or you can read it in a book, or you can quickly catch up with it with a little research. But in the case of COVID, at the time it broke, there was very little or basically zero information. So that was difficult to work out. In terms of virulence, it's not the most virulent infectious disease or pathogen that we have seen. It's certainly not as virulent even as Ebola, or certainly even as Lassa fever that we are currently experiencing in the country. But what's the difference is that because it achieved pandemic proportions, covered the whole world, and has resulted in, a little over 6 million deaths. That's larger than the population of many countries, even in Africa. That made it cause significant toil on the health of the world's population. Let's not even talk about the livelihoods and the economic damage that it caused as well.
And doctor, this also affected our attitude to infectious diseases, how we progress from lockdown to the use of face masks and staying away family members. But, you know, for what we've been told, the triage, which is testing, contact tracing, and the likes. Testing has remained low for a population like ours. And, you know, the question has been, why haven't we met the targets? Also, the information about the seroprevalence study, which appears to be saying another story, 50% of the population could have gotten COVID at some point. Clarify that for us.
Well, what we know, and you have reported this in the past, obviously, is that COVID did not affect the African continent as much as it affected other parts of the world. In terms of the number of cases, in terms of the number of people who died, every death is important, but as we all know, the predictions were of several orders of magnitude of cases overwhelmed, that we would have critical care facilities and hospitals overwhelmed, and there will be bodies in the streets, but that did not happen. Nonetheless, we clearly, the information from Sero surveys tells us that it's not because Africans were resistant to the virus, because the virus indeed achieved widespread transmission. And this is what the Sero surveys tell us. The Sero surveys tell us that several, a larger number or fraction of the population than reflects in the case numbers by testing had actually encountered the virus and developed antibodies to it, with or without actually developing symptoms. We also know that even from the cases that we've identified, most of our cases have been either had no symptoms, that is, they were asymptomatic, or they were just mildly symptomatic, which is why you can see from the numbers that we report daily and cumulatively that most of our confirmed cases were actually discharged and are alive and well.
So what does this information do, and this is for NCDC and other sister agencies, to the response of the virus, which is still very much around moving forward?
Well, I think the thing to say, to start with, is that the situation where you've got Sero survey results far in excess of the number of cases reported is by no means unique to us. This is the situation in Kenya, where I used to work before. It's a situation here, it's a situation in the UK and elsewhere. Because a significant number of people who come across this virus do not develop symptoms, a lot of the population have antibodies without ever falling ill. And we don't normally test people who are not sick. You might test a few people because they are contacts of people who have taken ill, or because they require it for travel or otherwise, but we only test people typically when they are symptomatic or they are suspected of having COVID. And this is part of why the case numbers are quite disproportionate compared to what our Sero surveys show. But in terms of the implications, it just tells us that when you've got a virus like this that's very infective and highly transmissible, it doesn't take much before it achieves general spread in the population. And that means that we really do need to be conscious of this. Should we have the misfortune, and I pray not, that we get a virus that is equally transmissible, but more severe in terms of the manifestation of illness in people who actually catch it.
Do you think that face masks will be around for the next few years?
The face masks have been around, as I'm sure many of us know, especially people who have the opportunity to travel frequently know that. I mean, they are, people from Asia and elsewhere typically use face masks because, I mean, they either to deal with issues of pollution or actually to take care of the challenge that they have with flu. So I think they will be around. I hope we don't have new waves of COVID, but with every exacerbation, or should COVID become seasonal, we might have to, at the season or when there are known risk factors, actually use face mask, even more than we previously have. And I'm talking now about a post-COVID future. Right now, I think people should still adhere to public health safety measures as recommended by the Presidential Steering Committee of COVID.
Thank you so much, Dr. Ifedayo Adetifa, Nigeria Center for Disease Control, Director General. Thank you for joining us on the program, albeit for the first time and hopefully the last time.
Thank you very much for having me.
Still to come, we speak to Professor Peter Pitts. He's a former Food and Drug Administration FDA Associate Commissioner, also named one of the 300 most powerful people in American healthcare by Modern Healthcare magazine. Please join us again. Welcome back. Well, do you see COVID becoming one of the many viral respiratory diseases that healthcare providers and patients will manage each year? What is the future of therapeutics and vaccination? Former FDA Associate Commissioner and President, Center for Medicine and the Public Interest, Professor Peter Pitts, joins us now on the program. Thank you for joining us.
Oh, my pleasure. Thank you for having me on.
I'd like to begin by using a term that you are familiar with, and that is coincidence or crisis. Was COVID-19 a coincidence or a crisis in terms of its origin?
Well, I don't believe in coincidences. Whether it was a man-made virus or it occurred naturally in the markets of China, as other viruses have, we need to recognize from a scientific perspective, from an epidemiological perspective, how to make sure that future viruses don't have the same breeding grounds. It's time to act on this as an international community, stop blaming people for what happened and looking forwards to a solution. There's a very important Japanese proverb that says, don't fix the blame, fix the problem. And I think that's exactly where we are relative to learning where COVID-19 came from, so we can make sure that future viruses don't have that same opportunity.
The US is also, one of the global leaders in science and medicine, but it also stumbled badly in its response to the pandemic. Is this something that resonates with you? And what would you say was the key thing that was responsible?
Well, I think the lesson learned here is that we were, as a global community, completely unprepared to deal with any type of pandemic. We didn't recognize the need to reach out across borders immediately, to share science broadly and with immediacy, and to make sure that every country on earth has the tools that it needs, because we live in a global community. What affects China on Monday is going to affect the United States on Wednesday, and Europe and Africa, and so on and so forth. So I think one of the lessons learned is we need to be prepared together. We need international responses together. This isn't, strictly speaking, something that any nation can deal with on its own on an ongoing basis.
And sadly, that hasn't happened. The tools, therapeutics, the drugs, vaccination, and also for, Africa is one example. But what's your take on how you think the continent of Africa has weathered the virus compared to other regions of the world?
Well, I think every region of the world has done poorly. Unfortunately, Africa suffers from a lack of resources, from a lack of manufacturing capabilities, and really relies on other countries, whether they're Western countries or China and India, for their supply of vaccines and therapeutics and diagnostics. Testing is also key, and I think Africa has really fallen behind, certainly the West, in its ability to test. And testing is obviously a key component of managing issues like COVID-19. I think as we go forward, one of the lessons learned is that Africa needs to rely not just on the WHO and on the good intentions of other nations, but as a continent equal with every other continent, with countries equal as every other country, and make sure that its requirements are as important to the rest of the world as the United States and Europe.
Professor Pitts, let's come to COVID-19 drugs. Are there any that works?
Well, I think that obviously therapeutics were slightly ahead of vaccines. The drugs that allow people to have COVID-19 and yet not suffer serious manifestations and be hospitalized and die have been extremely successful, from the Gilead drug remdesivir to products from GSK and from Pfizer and other places. Therapeutics have played an incredibly important role in making COVID-19 a non-deadly pandemic. Clearly vaccines, are the way to go relative to protecting an entire population, and we have to make sure that all of our populations get as completely vaccinated as possible. And we need to recognize that it's not a one and done proposition, not in the West, not in Africa, not in Asia. We're going to probably need annual COVID booster shots, just as we have in the US annual booster shots for the flu. We're going to have to recognize that if one person's protected with a vaccine, we all become better protected. And as a fallback measure, we have therapeutics that can help people that do contract COVID-19 to successfully get through the course of the disease and move on with their lives.
I know that the FDA approved the antiparasitic drug ivermectin to treat several tropical diseases, but what role does it play in preventing and sort of treating COVID-19?
One of the important caveats about science is that the plural of the anecdote is not data. There is no real reliable data set that shows that ivermectin really is effective against COVID-19. I think that, looking to an inexpensive generic drug to solve the world's problems when there's no evidence is putting hope over science, and that's not practical. We've got to follow the science. Ivermectin is not one of the drugs that really can help us. Similarly, with hydroxychloroquine, the data sets are very thin. The only serious data we have are for vaccines and for the therapeutics that were developed specifically to combat COVID-19. So, crossing our fingers and hoping that a cheap and effective existing generic drug is going to set us free from COVID-19, unfortunately, I think is a naive proposition.
Is that the same way you would feel on about hydroxychloroquine?
I think so. I mean, initially there was some hope that hydroxychloroquine might be a partial solution, but again, a lot of science has been done on hydroxychloroquine, and the data says that it really is not a solution. I wish that were not true. I wish that we had a inexpensive, readily available product to combat COVID-19. Hydroxychloroquine, unfortunately, does not suit that bill, and there's a lot of data to support the fact that hydroxychloroquine is, in fact, not a solution. So we've got to recognize that we have to follow science, even when it tells us things that we don't want to hear.
But I'm sure there is also data that a lot of people, a lot of hospitals mixed and matched, drugs, just so that people can get well, over the months of COVID-19. But also, since the COVID vaccines became available, we've been told vaccines, booster shots, the best preventive measures against severe illness, hospitalizations and death. Yet not everyone believes that. How do you convince people of the science when vaccine hesitancy is also very rife?
Well, that's an amazing question. Thanks for that. What we've discovered in the West and certainly in Asia, in fact, I was just in Dubai last week having this exact same conversation with Arab states, is that we have an abysmal state globally of health literacy. The populations of the US, in Nigeria, in the Middle East, in Europe, everywhere, really don't understand what the science says. And if you don't understand what the science says, you can't follow the science, and you're likely to want to believe more simplistic solutions that give you easy answers to complex questions. So I think moving forward, one of the ways that we address COVID-19 and avoid future pandemics is to really ramp up health education in all of our countries. And it can't be one size fits all. We have to look at health education from a national level, from a state level, from a municipal and tribal level. We've got to be extremely granular in the way we get these messages across. We want people to understand them and internalize them and act on them. And I think that there's great possibilities if we understand that the better educated our public is, the more likely they are to do the right thing relative to COVID-19, be it wearing masks or getting vaccinated.
Do you think that there is every reason to expect another pandemic?
Oh, I think it would be naive to think this is the first and last pandemic of our lifetime. And, Bill Gates said the other day that he thinks the next pandemic will be in 3 to 5 years. I don't know how he knows that. I haven't had a chance to look inside his crystal ball. But from a straight scientific epidemiological perspective, let's face it, the next pandemic is just around the corner. We live in a very small world. Airplanes are flying all the time. People are moving around the world regularly at great speed. We have to be prepared, and we need to recognize that need for preparedness begins right now.
Professor Peter Pitts, thank you, visiting professor at the University of Paris School of Medicine. Thank you so much for joining us on the program.
My pleasure. Thank you and good luck.
To you as well. Our website, channeltv.com, has more updates. Also a better understanding of the pandemic, which we will feature the latest stories at your fingertips. Well, that's our program for today and for a bit. Thank you for joining us. I'm Millicent Walker. Stay healthy.